and that's who I am. That's other things. Yeah. I always put my declarations of interest up to start with, just to prove that when it comes to the industry, I am a bit of a tart. But I'm not a prostitute, so I don't change anything I say. You may agree with things I say, or you may disagree with things I say, but there are always references on there, and I'm always willing to discuss them. But also, all this lot here, apart from giving me a pain in the neck turning round, I don't get any money for many of those, so I figure it all works out that even. What I was going to say, I think brains are marvellous, but humans go wrong. Medicines can help, and respect your brain. Those are my sort of key messages. So I probably better get out now while the going's good. But that would make Mike's videoing a bit pointless, really, wouldn't it? So I'll say a few things. So brains are marvellous, utterly marvellous. But we've got to remember where we come from. Where we come from was the Big Bang 13.5 billion years ago. So this is a little graph that shows that's when the Big Bang was. That's time along here. And we're on this border here. So the universe expanded enormously to start with, and then it carried on expanding. And it's beginning to expand, but quite a lot. It's beginning to build up speed. And the Earth was formed about here. So the Earth is probably about 4.5 billion years old. And then actually, wrong order. So 4.5 billion years old. So this is just a way of looking at it that nothing much happened for that length of time. And then we've got bacteria sort of started around there. And then 2 billion years ago, they got a bit cleverer. And then really in terms of the development of the Earth, that's the dinosaurs there, 160 million years ago to about 60 million years ago. And humans, as we know, as we are at the moment, we're the last tenth of a second of that 12 hours. If you put that and spread it out so it was a metre long, then the time since the Second World War stopped, the thickness of that, of a metre, would be 30 carbon atoms. Just to put it into... So, not very much. So we've got to remember we actually got here by developing all of this length of time, probably partly because of our moon. Not only the fact that we've got water, but our moon keeps slopping everything around. So if you want chemical reactions to occur, you just sort of wiggle it a bit. And that's what's happened to Earth. So that's where we got to. We also have to remember that one of the only reasons we're here now is because a big meteorite hit Mexico about 65 million years ago. That meteorite hit the Earth. It caused a sort of nuclear winter. It killed off about 90% of all the species that were growing at the time over the next 100,000 years, including all the dinosaurs. And because of that, we developed as a result of that, because obviously we'd never have developed when there were dinosaurs around, because they'd have eaten us, wouldn't they? So, and we're only here now because of that. So we have to remember that brains are marvellous, but we've developed through all of that, and we are a being. So we can get terribly intellectual about it, but we have to remember that our little lifetimes are not the sort of what we think as being an enormous length of time. In terms of the universe, it's actually nothing at all. And we've got to be careful about atoms, because you've got to be careful because they make everything up, including ourselves. Yeah, that's the number of atoms in the human body. To save you counting it, it's 27. I counted it earlier. So we're you're wondering where this is going to, aren't you? Snap. Sure, there's a story in there somewhere. So that we are chemicals. We are humans, and we think we're special. But actually, the human brain is quite. It is a well-developed thing, but it is made out of chemicals. And if there's 100,000 million brain cells or neurons in our brains. Each of those has got anywhere between 1,000, 5,000, and 500,000 connections with other brain cells. There are 4 million miles of brain fibers in the human brain. What else is there on there? 100,000 miles of blood vessels in the brain. So it's incredibly complex, but it is made out of chemicals. And that's the number of number of messages, essentially, 400 billion messages passed every second in the human brain. So incredibly complex, and if you look at that, you think, who invented boxing? It seems daft, but there you go. And it's awesome, it functions 24 hours a day, except when you do an exam or fall in love. We've not even got the biggest brains. I mean, this is excluding whales and things like that. Giraffe brains are actually bigger than ours, but ours are seem to be much more adaptable. But anyway, the brain is the most important part, most important organ you've got, but that's only according to the brain. So, well, just think about brains while we're on the subject. That's pretty boring, isn't it? That's the better one. That's probably sexist, that really, but who cares? But if we're going to be not sexist about it, how about that? Yeah, if you can't see it, under the male brain, it says the listening to children crying in the middle of the night gland is not shown because it's too small, an underdeveloped nature. So anyway, brains are different from each other. Now, within that brain, we've got brain cells, probably around 10,000 million, 100,000 million brain cells. They have a specific structure. They do vary from different parts of the brain, but essentially you've got a nucleus in the middle, you've got the cell body there, you've got nerves coming into the brain cell, they're taking messages in, and then the centre decides what to do, then it sends messages out along this axon that goes off to another brain cell, or a whole range of brain cells. So you've got all of these nerve fibres coming in, anything up to 500,000, lots of messages coming in, which are then processed by here, and we really don't know how brain cells work or what they do, or how they do it. And then the messages are passed out, and then they will go on to other brain cells, and they'll come in like this to that brain cell and pass the messages around. You've got blood vessels in there to keep everything oxygenated and alive. You've got astrocytes and microglial cells, which keep the cells healthy, feed them, and make sure they're okay. So we've got 100,000 million of those in our brain, which is, they're not very big really, are they? But they're very clever. They do all the things that we've evolved to do. Now, one of the most important parts that we know about are these synapses. Now, we know about synapses, they're junctions, because those are the parts of the brain that's the way in which the messages are being passed. And we don't know much about brain cells themselves, but synapses are the same in all animal species pretty well. The structure is the same, the way they work is the same, how they pass messages are the same, but the complexity increases the further you go up the evolutionary tree. So we know quite a bit about synapses. That's a picture of a brain. The green bits are the cells, the blue dots are the synapses. The next one's a very magnified electron microscope scan of a brain cell itself with all the nerve fibres coming in and all the junctions and so on. Now, synapses are quite important because we know this is the way in which brain cells communicate with each other. So that's what a synapse looks like. So you've got a nerve fibre over there. Which direction? That's... Yeah, so there's a nerve fibre over in the city arriving, and there's another nerve fibre goes over to Cringleford over there. Is that, no, Wyndham. Heatherset, that. Is that right? That'd be that way, won't it? Yes, or Watton or somewhere like that. Anyway, so nerve fibre comes in, you've got a swelling at the end of that nerve fibre. You've got vesicles inside there, which have got transmitter in them, which are small chemicals. You've got a gap, which is called the synaptic cleft. And then you've also got the nerve ending here, which has got an end plate there, which has got a load of receptors on it. And then the nerve fibre goes off over that direction. So if you've got a brain cell in Norwich, wants to send a message to Heatherset, this is what it does. The impulse comes along, It's a bit like an electrical Mexican wave. So it comes down the nerve, 120 feet per second, if you're interested in that. As it arrives, so these vesicles here fuse with that end plate. They release the chemical that's in there. The chemical is in there, travels across that gap, hits the receptor on the other side. As it hits the receptor changes shape. As it changes shape, it triggers off a series of changes in that end plate there. Often it'll open up and ions will go through. That triggers off an electrical impulse, and then the electrical impulse goes off like the electrical Mexican wave down off to Heatherset. The transmitter is taken back up into the nerve endings, and then it resets itself. And that's how a message is passed. Takes about 1,000th of a second. And if you think how quickly how many messages need to be passed, because if I say something really quickly like this, you can hear the words, and you think how many changes in your vocal cords are necessary to do that. That gives you an idea of how quickly these nerves. So that's how the messages are passed. It only works one way. There are a group of transmitters in there that are released and hit. Those receptors there are designed just to accept that transmitter in there. There are about 200 different transmitters that we know of. It only works one way. Yeah, and that's it, yes. So that's how the brain works. In fact, that's actually how all nerves within the body work. That's where the junctions of them are. Now, we've developed over all this time, but we've developed to the point where we actually survive a lot longer than we were ever intended to. In evolutionary terms, once you've survived past childbearing fertility, everything else is a bonus. And we have, I've got particularly poor eyesight. I wouldn't have survived because I wouldn't have been able to see anything coming towards me to attack me, to eat me. So I would have died out. But, because we've invented glasses and we're quite clever at that sort of thing, then, I'm here now. But we do go wrong, and lots of things can go wrong. Just a series of conditions I put up there, random ones: diabetes, hypertension, asthma. All of these things, bits of our human body go wrong, and they can be caused by, external injury. It can be your genetics. Poor eyesight runs in my family, so almost everybody wears glasses. Where that's a genetic variation or a vulnerability. It just happens that we've survived because people have invented glasses and we've been able to see what's going on around us. We probably wouldn't have done otherwise. We've got genetic vulnerability. We are more susceptible to something happening. So lots of things can cause things to go wrong in the human body. It doesn't work 100% perfectly all the time. No human or any animal works 100% perfect all the time. So if we go back to this, so we know we've just talked about that. Now, if you get imbalances in the chemicals in your brain or in the body, it can cause it to malfunction and things go wrong. So if you look at this, I have to move back a bit over here. So for instance, in the brain there is dopamine as a transmitter. Dopamine looks after lots of different things in the brain. It looks after your reward system. It's the part of the body that when you take information in, it processes it and decides what's important and what isn't important, which is called salience. Salience, that's right. What's important and what isn't. It's also involved with movement, muscle movement. So it controls how much you move your muscles and when you move them and so on. And with all of these chemicals here, and some of those are in the body and some of them aren't, then too much or too little causes symptoms, causes things to go wrong. So if you've got too little dopamine in that movement area, then that's what causes Parkinson's disease, because you get not enough messages to the body to move your muscles, so your muscles don't move, they stiffen up. In fact, the dopamine actually tells your muscles to relax. They stiffen up, and that's where Parkinson's disease comes from. If you've got too much in the perception area, then brain begins to become overactive, and that's often where the symptoms of psychosis come from, because you start making things up. You know, there's somebody coming in at the back of the room there. If my brain was overactive, it might go, well, hang on, they're coming into the room at the moment. I might start thinking about how they come in now, because actually there's loads of people around there that are going to attack me, and the reason why people are moving around out there is because, you know, the SAS is out there and aeroplanes are flying around. So your brain becomes overactive. Too much dopamine, and you can become psychotic. Serotonin's involved with mood, appetite, and sleep, loads of things. If you've got not enough serotonin, we know that in some parts of the brain that causes migraines. Other parts of the brain, you've got not enough mood, so you can become depressed. If you've got too much in the appetite areas, then that can make you feel sick. It's often a side effect of some drugs, antidepressants, cancer treatments, and so on. Adrenaline, that's the fight and flight, which was mentioned earlier, attention. Drive. So if you've got not enough attentional drive, then that will cause fatigue and depression. If you've got too much, then you might have too much energy, heart racing. Possibly one of the things that might happen in bipolar. GABA is the inhibitory one in the brain. If you've got too much inhibition, then you're sedated. If you've got not enough inhibition, then you can get anxiety, perhaps you can get poor sleep, perhaps you can get seizures. Glutamate, that's the excitatory one, which if you've got too much of that, that can possibly cause Huntington's disease. And too little of that, then you get not enough excitement, so not enough alertness, so you can be sedated, poor learning, poor memory. But it's not just the brain, it's everywhere as well. So thyroid, the thyroid gland produces thyroid. If it produces too much, then you have hyperthyroidism. We can be very agitated, heart racing, weight loss. If you've got not enough of it, you've got not enough metabolism, then you get fatigue, weight gain, low mood, and so on. Histamine, we know about histamine, antihistamines for hay fever and so on. In the body, it's to do with the allergic reaction. Histamine in the brain is involved with keeping us awake. That's its role in the brain. So when you take an antihistamine that's sedating for hay fever, then it's blocking the drug that keeps you awake, so it sends you to sleep. So that's one of the problems with antihistamine drugs, or any drug that blocks histamine, is it can cause sedation. Acetylcholine, that's involved in the body in muscle movements, but in the brain it's to do with memory. So if you haven't got enough acetylcholine, then you haven't got enough memory, you can't lay down memory, you can't recall memory, spatial awareness, social function, those types of things. So what I'm trying to do here is just point out that differences in chemicals in the brain, because we're all made of chemicals, differences in chemicals will make symptoms on the outside. And I'll come back to this in a minute and try and make a point about it. So the world has changed, we've developed, we've adapted, but it's not really surprising that something as complex as a brain doesn't work 100% all the time. It's quite delicate, it's quite easy to disrupt. And you know, in terms of evolution, the world's changed so much in the last 50 years, it's not really surprising that we don't necessarily get on with the world as well as we could. But in fact, it's not necessarily survival of the fittest, it's survival of the people who adapt the most, and humans seem to have an amazing ability to adapt. But we aren't going to live any longer. So with all the developments in medicine, we're not going to live. Individuals might live longer, but overall, you can see if you look back from figures, what is known about what happened in the 13th, 14th century or whatever, there was a huge drop off here, and then the number of people surviving did that. You can see as years go by, that graph is moving, but it's still not going to get much past there. So, that seems to be the length of time that we live for. So, if we know that chemicals can go wrong and cause symptoms, then the point I'm trying to make is that if you can use medicines to help that. Medicines are chemicals, and it's difficult to read that. We've got to be careful about, we are made of chemicals. So yes, drugs are chemicals, and I think It's a lovely comment there. Whether or not a chemical is man-made or natural tells us nothing about how dangerous it is. Neither does it make any difference about whether or not you can actually pronounce it. So, you know, people get terribly excited about E numbers and things like that. You know, they're all chemicals. The body is designed to take chemicals. Everything is made out of chemicals. Apples, tea, coffee. There are 500 different chemicals in a cup of coffee. Very few of them have been tested whether they're safe, but the body is designed to take chemicals in, deal with them and get rid of them. Think how many chemicals there are in all those different foods that we eat and chemicals. So chemicals, you've got problems with chemicals in the body, and we can help with chemicals can help correct some of those. And what we know within the brain is that many of the symptoms of conditions are caused by there being too little or too much of different chemicals within the brain. Now, I'm not saying that's the cause of the condition, but the symptoms may be caused by that. So if you've got too much dopamine, that may well cause you to become psychotic because that part of the brain becomes overactive. But it doesn't mean to say that what we don't know is why there's too much dopamine. Now, if you were all to go home after this and smoke an enormous joint, that's just hypothetically. If you were to do that, then, and you had a lot of cannabis, it would stimulate your cannabis receptors, which would stimulate dopamine in your pleasure centers. If you have enough of it, it's going to stimulate dopamine everywhere else, and that's where a psychosis can come from within a usual normal brain. By having too much cannabis, too much dopamine, you become psychotic. So cannabis-induced psychosis is caused by there being too much dopamine in the brain, caused by something external. So we can make everybody here psychotic within about an hour, I would think, if you took the right chemicals and the right combination, which would boost dopamine. So depression as an example, we know that if there's not enough serotonin or noradrenaline in the brain, or it's underactive, then that will lower your ability to regulate your mood. And if you do that, then your mood goes down. So it'd be good if we had a chemical that boosted the amount of noradrenaline or serotonin in the brain. What causes that is another question. Could it be stress? I mean, it's lots of different possible causes, and I'll come on to one in a minute. Bipolar, it's particularly, you know, in terms of evolution, bipolar is, you know, somebody bipolar manic, a bit hypermanic all the time. It's quite attractive, actually, is a good catch because they'll be off around catching things and providing lots of food and so on. It's a good evolutionary attractiveness. Schizophrenia we don't really know too much about. Possibly doesn't occur in other mammals apart from ourselves that we know of, but it might do. There's very interesting stuff recently about immunity and whether in fact schizophrenia is an immune response to something. There's been quite a lot. Ollie Howes in London's doing some work on it. And it could be that some early psychoses are actually an immune reaction to parts of the brain triggered by some type of infection. ADHD, for instance, another example. You've got too much, you've got possibly not enough dopamine, so the person's constantly trying to have excitement to boost their dopamine to feel normal. So we know that the changes in chemicals will cause symptoms. We don't necessarily know what causes the change in chemicals, but we know that the chemicals changing will cause symptoms. So just taking depression as an example. Now, don't worry about the long words on here. I'm just trying to make the principle, the point here. But the point here is you can be under stress, under life events. That could be any type of stress. It could be any type of life event. It's how you react to it is part of it. Your cognitive style is part of it. It doesn't even have to be anything you even notice. But if you're under stress, that activates the HPA axis, the hypopituitary adrenal axis. Don't worry about that. If you activate that, it releases CRF, which stimulates adrenocorticotrophin, which stimulates the adrenal gland to release cortisol. If you release cortisol, it suppresses the release of serotonin and noradrenaline, which means you get less serotonin and noradrenaline, which means it lowers mood. Now, of course, if you think, Winston Churchill was mentioned earlier, wasn't he? Now, Winston Churchill, first he was an MP, and for about, if you look at his life history, for about 2 years he suffered from really major depression, and he didn't do anything. But he was a Tory MP in a safe seat, so it didn't really matter. It didn't matter in the 1920s anyway, so he just didn't do much for a couple of years because he was so depressed. And then he came out of the depression, he was okay again. Now, can you imagine that happening now? No, possibly what we could look at is think, well, actually that's the brain's natural response. If something, if you were a monkey and you broke your arm, then what's the best way to survive? Keep quiet, not eat very much, not make much noise, don't attract attention, don't be a drawer on the rest of your group. And then when you're repaired, you join them again. That just like depression, in fact. So it could well be a response to something, and actually perfectly normal. But of course, these days, we're not allowed to be depressed for 2 years and not do anything, because we've got to be happy and cheerful all the time, haven't we? And normal and doing everything else. So, and of course, if you've got lower mood, that makes you less able to respond to stresses, and so it goes round and round and round. And so one of the points I would make is that, yes, we know medicines can help increase serotonin and noradrenaline, and of course psychological therapies can help you with that. And it doesn't normally be sometimes when people say which one's better. If you look at that, they're different. So they're actually working on different areas of a problem. So in fact, they may well work better together. And a lot of the research into depression now is looking at, well, actually, can we do something about that, or can we do something about that? Let's try and attack the problem at a different place. Ketoconazole, I don't know if anyone's ever had that. It's an antifungal. It actually has an effect on this bit. Fantastic antidepressant. Really effective, provided you can take it at the dose that works. Because the dose that works gives you so many side effects, it's better to be depressed. But it does prove that if you affect that, then you're beginning to. So this does work, and if you're affecting that, then you can affect depression. So what we know the antidepressants do is, if we go back to our normal transmission there, a depressed ambition, we know there's not, the activity or the potency of serotonin and noradrenaline isn't as high. And then what most of the antidepressants do is they block the reuptake of the transmitter back into the nerve ending. If you block the reuptake, it means that there's more transmitter hanging around. So the next impulse that comes along, you've got the transmitter being released from here, plus the stuff that's already left over, and then you get a stronger message being passed. And therefore, if the symptoms are caused by there being not enough serotonin and noradrenaline, then you're boosting it. It's a bit like WD-40 for your nerve endings. It sort of increases the spark that's in there. Then it will strengthen that message. Then you increase the serotonin and noradrenaline. Then you're more able to cope with the stresses and so on from that. That's basically how most of the antidepressants work. Now, a lot of people say antidepressants take 4 weeks to work. Okay, they don't. They're quicker than that. What people mean to say is antidepressants take 4 weeks before you can prove beyond any statistical doubt that they work. But in fact, there's been studies which have shown that antidepressants actually start to work in about 3 hours. And you can begin to show lots of differences in all the rating scales within a week. So if someone's taking an antidepressant and they start to improve fairly quickly, don't be put off thinking that, well, it can't be the antidepressant because that takes 4 weeks to work. It doesn't. It works quicker than that. It's just 4 weeks. 4 weeks to get the full effect. Their greatest effectiveness is in stopping depression coming back again. And I'll show you something in a minute on that. They do not cause suicide. They're still got a reputation for causing suicide. They might increase the risk in people under 20. That is quite possible, and that's possibly due to the fact that, as Dr. Solomka said this morning, if you give antidepressants to somebody who's got bipolar depression, that can actually make them feel worse. And first episode of bipolar is often depression and in young people, and the symptoms are the same between unipolar and bipolar depression. So it's possible that actually, and the figures do stack up, that actually that increase in suicide thoughts and ideation is actually in people who have got bipolar disorder given antidepressants. But apart from that, all the other large studies, and there's one which is almost 500,000 people, showed that they significantly reduced suicidal thoughts and ideation. So they do not cause suicide. The dose that gets you well keeps you well. The BNF, the British National Formula, used to say they work, but and then once people have been on for a while, try reducing the dose to a half. That's wrong. It's the dose that gets you well keeps you well. So don't try reducing doses. Keep going for the right length of time. I'll deal with that in a minute. And starting slowly and stopping slowly is an important point. I'll deal with that as well. That doesn't mean to say they're addictive. And all that comes from proper studies. So how well do antidepressants work? This is something that I've done for the Choice of Medication website, which I'll mention as well. This is people, so 100% of people have got depression at the start. If you take an SSRI, so that's paroxetine, citalopram, escitalopram, fluoxetine, Prozac, sertraline, then 40% of people will recover at 6 weeks, and 60 to 70% will recover at 3 months, and it's 70% by 2 years. If you have placebo, and this is done in the same studies, which are double-blind studies, so nobody knows who's getting the treatment or who's getting the placebo. They're randomized, so you just choose a whole load of people and randomly put them in 2 different groups. Placebo response is about 20, 30, or 45%. Interestingly, placebo, nothing at all, still gives you 20% response at 3 months. So that's, so you can see this interest in that, being given a placebo is definitely being given something that's nothing is better than being given nothing. Does that make sense? No, probably not. I'll shut up. Because it's a fascinating thing that we were talking about on Wednesday, actually, was that in the clinical studies that are being carried out at the moment, the number of people who respond to placebo has been gradually increasing for the last 30 to 40 years. So more and more people are getting better on placebo, a dummy tablet. It's very confusing, looking at studies really difficult to do. Anyway, it's quite clear that they are having an effect on depression and also keeping people well, more than placebo. Keeping going for the right length of time, we know that for a first episode of depression, if you carry on for 6 months after your symptoms have improved, then your chances of becoming depressed again are much lower than they were if you stopped quicker than that. Second or third episode, probably 3 to 5 years. And obviously the choice is yours, but if you've had 4 or more episodes of depression, then the chances of you becoming depressed if you stop an antidepressant are very high indeed. That's people who had 3 episodes of depression in 5 years. That is the people who took antidepressant, and that's what happened to them. That's people who had interpersonal therapy and antidepressant. That's people who had placebo. That's people who had interpersonal therapy by themselves. So you can see from that up to that point, antidepressants were pretty effective. They were even better with interpersonal therapy. Placebo interpersonal therapy, I'm still trying to get someone to explain me how you can have placebo interpersonal therapy, but they did. But after 3 years, that lot there, half of them carried on with antidepressant and half of them stopped. And you can see how many people relapsed from that graph, on that graph. So clearly the antidepressant in that group of people, who were a pretty ill bunch of people, it was obviously still having an effect, those people up there. It's interesting, half of those stopped taking the antidepressant because they did plasma levels, blood levels at the same time. So I won't go into numbers needed to treat in great detail, but NNTs is quite an interesting way of measuring the effectiveness of a treatment. So an NNT of 4 means that you need to treat 4 people to get one person to respond more than if you'd given them a placebo. So it's just rather than having percentage figures and so on, it's a number of people you need to treat to get a result. So for instance, heart attack, to prevent heart attack, low dose aspirin, which loads and loads of people take, actually you've got to treat 208 people to stop one person having a heart attack. But low dose aspirin, cheap, non-toxic, you know, low risk, you know, it doesn't really matter too much. Generally, NICE generally works on the principle if you've got an NNT of under 10, that's good. That seems to be their sort of cut-off. Interesting, the NNTs for treatment of depression is 4 and preventing relapse is 3, which is phenomenally good. Just adult ADHD, believe it or not, is 1.1, which is as good as treating a peptic ulcer with omeprazole and things like that. So they are really, really good NNTs. And as I say, if you're happy and you know it, stick with your dose. I'm very aware of the time. Antipsychotics, we know too much dopamine causes the symptoms of psychosis. The one thing all antipsychotics do is they block dopamine receptors. So they go into the receptor, block it, a bit like putting a Yale, you put a wrong Yale key into a Yale lock. You get it in, can't you? It doesn't turn it and you can't get it out again. So that's essentially what antipsychotics are doing to receptors, dopamine receptors. They're going into it, they're blocking it, they're stopping the messages being passed. So if you reduce the amount of dopamine, then the next message that comes along isn't as strong, and therefore you reduce the effects of too much dopamine. It's imperfect. The drugs also block other receptors, so that's why you get side effects. But that's essentially all. No one's yet found a drug that reduces psychosis that doesn't have an effect on dopamine. Now, if you're interested in those graphs and tables and things like that, if you go to the Choice of Medication website, you can print out a whole booklet which has got all of those in for every condition, every mental health condition. It's free to download. Things about antipsychotics. Too much dopamine causes psychosis. All antipsychotics reduce the effect of dopamine. If an antipsychotic hasn't worked within 2 weeks, it's not going to, if you can't see any difference. That's some recent research that's been put together, that if it hasn't worked in 2 weeks, it's not going to. If you haven't seen a difference in 2 weeks, it's not going to. The dose that gets you well isn't necessarily the dose that keeps you well. So that's different from depression, that with antipsychotics you may actually need a lower dose to keep all those receptors topped up. Whereas with depression, it's the dose that gets you well, keeps you well. And it is one of my little fears that often people forget that and they think, well, the dose that, you know, so-and-so's got better on, you know, I don't know, 500, you know, 20 milligrams of olanzapine, therefore we've got to keep them on 20. Actually, reducing the dose might therefore reduce the side effects and still have the same effect of preventing relapse. And the other thing is that one of my little bugbears is that atypical antipsychotics, which you might have heard the term used, is a completely useless term. It means nothing. It's a marketing term, and it's misused and thrown around the place. All antipsychotics are different. They're all effective, but they're all different. They have different efficacy. There's a gentleman this morning who was doing very well on aripiprazole. He said that was brilliant, didn't have any side effects. Other people, aripiprazole is terrible for them. Some people do well on clozapine, some people don't. So they're different. All our brains are different. We don't really know what's wrong, but they're all different. But just because something is atypical, it doesn't mean it's better than something that isn't. All atypical antipsychotics are the same as each other, because they're not. They're all very different from each other. Now, bipolar, we've already dealt with that this morning, so I won't say too much about that, other than the Choice of Medication website, which is available through the Trust. I'm just trying this out at the moment, which will be putting in, these are comparative charts to help you choose which drug is the best for you. But you'll notice that under bipolar mood disorder, there's some columns here based on how effective it is at stopping manic relapses, how good it is at stopping depressive relapses, and how acceptable it is. Now that's a bit scary, isn't it? Well, it is for me anyway. Telling people which drugs are the good ones and which ones aren't. Is that something I should carry on trying to do? Good, thank you. That was the right. I'll carry on doing it. I can't do it for all drugs yet, but this is if I can find a good review that reviews everything. So bipolar depression. So acceptability is the number of people who dropped out of the trials. So finally, finish off with right. Respect your brain. Don't believe everything you read in the newspapers. Newspapers are not very good. Their idea is to sell newspapers. It's not to give you good quality information, as long as you can sell information. So they'll take words out from studies. The animal studies then become new wonder drug, because animals are different to us, funnily enough. They just don't understand some things. I don't know if I got rid of it. There might be a slide later, which I was going to... I can't remember which one's coming now. Anyway, so get medicine into perspective. Okay, everyone's expectations of recovery is that, and what we know happens, of course, is that, isn't it? Symptoms didn't appear overnight, and they don't disappear overnight. They take a while. Your brain's got to get used to it. It's a functioning machine made out of chemicals, so you put other chemicals into it to help it work better, but things don't change quickly. You've got this triangle of care. And I always think the best outcomes are really where you've got medicines to help control the symptoms, therapy to help you, help from others to help you live with it, and then you have to help yourself as well by reducing stresses and so on. There's a famous psychologist from Pittsburgh called Kay Redfield Jameson. I don't know if any of you have ever read her book called The Unquiet Mind, about suffering from bipolar disorder. Very eloquent lady. She said, she's on lithium. She says, lithium helps control the symptoms, therapy helps me live with them, which I thought actually summed it up rather perfectly. And that, of course, all those sort of things, diabetes, insulin is vital for diabetes, but if you don't know how to use it, you have to have other people tell you how to use it. And you have to look after your diet, look after yourself. So there's all those three parts of it. And yeah, okay, your therapy can be a combination of drugs and clowns, but one way I look at it, it's a bit like, if you've got a three-legged stool, so you've got self-help, help from others and medication on all those three, you could be quite, sat down on that, you could be quite stable. If you take one of them away, yeah, you can wobble, but, if you're a bit more vulnerable, but, you can still survive. And it took me a long time to find a picture of a one-legged stool. But if you've got one-legged stool, okay, yes, you can do it. Have a wobble and you might be struggling. And to go with that, I really say, and I'm going to say this in a second anyway, that's all I've got left, is if you are going to, if you're sat on a three-legged stool and you take one of the legs away really gently, it gives you time to adjust and to settle down. If you whip it away quickly, you're going to fall over. So I would say with all medicines, if you're doing anything, do it gently, give yourself time to get used to it. It's a bit like a pair of, think of drugs as water wings. If you've got a child trying to learn how to swim, okay, you put water wings on them and they can swim. You don't just take the water wings off, do you? You just let a little bit of air out, and then they get used to that, and take more out, and then eventually they're okay. So it's a bit like drugs as well. Don't whip them away quickly, because you could sink. Do everything gently, and respect your brain. And looking at it, yeah, does it help you get on with your life? If it does, what's the problem? Does anybody, how many people have we, well, I'm sure there are people in this room who are taking medicines for long-term problems, be they mental health or physical problems. How many people know? Nobody knows if you're taking something. So if a medicine's actually helping you get on with your life, I don't see what a problem there is. There's more a problem actually if you then become ill again, then people do realise. So look after your brain. Think about sleep, making sure you sleep well enough if you can. Sleep hygiene's never been proven to work, but it's quite a useful thing to look at. eating, stress, activity, not too much alcohol. Caffeine, don't forget caffeine. Oh yeah, sleep, by the way. Avoid looking at backlit screens before you go to bed. In the 1 to 2 hours before you go to bed, television screens, computer screens, phones, iPads, anything with a backlit screen, LED, produces a blue light which prevents your brain producing melatonin, and melatonin is the message to the brain to go to sleep. So be careful. If you can't sleep, avoid backlit screens for a couple of hours or an hour or two before you go to bed. If you've got to watch a screen, get some tinted yellow glasses. You can get them for £5 off Google or eBay or something like that, because that then cuts down the blue light and your melatonin can produce itself and you can go to sleep. So be careful of that. Be careful of caffeine. I'm very careful about caffeine. So look at the figures on there. Much above, up to 500 is generally okay. 750 is a bit high, and above 1,000 is into the toxic range. Most people here would fail a drugs test at the Olympic Games for having too much caffeine because it's a stimulant. And some people with anxiety problems are much more susceptible to caffeine. Now, that's my motto, that one. But if you look at the symptoms of too much caffeine, irritability, anxiety, insomnia, headaches, palpitations, psychosis. So caffeine is often going to make those things worse. If I can just if you imagine that roughly brewed coffee is per mug is about 150 to 200, instant coffee is about 100, tea is about 100, no difference between those two really. Allegedly, Coke is 36 milligrams per can. I don't believe that one bit, but they keep it all very quiet as to how much caffeine's in there. So just have a little tot up at some point. All these figures are on the choice medication website. Just gradually reduce it. Treat your brain with respect. Making them more dilute less often. Start medicines gently. Always start them, with the exception of metazapine. That's the only one you should start the full dose. But the rest of them, always start things gently, get your brain, get used to it. Give it time to work. Make sure you get a dose that works for you. Don't, as was mentioned earlier, the Goldilocks principle, if you can get the right dose for you that's not too high and not too low. It's easy for me to say this, it's much more difficult in practice. But give something time to work, give it the length of time to work, only change one thing at a time. And stopping and starting is a bit like driving a car with your foot on the brake and the accelerator at the same time. The car's going to be jerking along. That's not kind to the brain. And if you're coming off of medicine, as mentioned, if you're thinking about it, we've got a handy fact sheet on our website which gives you some of the ideas to think about, and you can give yourself a little score. It's not positive or negative, it's just saying make sure you think about it. So think about what the problems of taking a medicine, not taking one, of stopping, how to choose the best time, and then how to do it safely and at the right time. And don't see medicines at a failure. And finally, to say, if you want to learn about medicines, if you go to the Trust website, if you go to learn more about medication, it gets you to the Choice of Medication website, which I can thoroughly recommend because I write it. So any comments come straight to me. But you've got at least 155, if not 160 drugs available on the website. There are 30 questions and answers on each of those drugs. There are 22 conditions, and there are anything up to 20 questions on those 22 conditions. Everything is interlinked, so you can go onto one condition that says these are the drugs that are there. You can look at them. Those are the questions, so you can look at all the answers or just specific answers. There are leaflets on loads of different things. So we've got 2-page leaflets on drugs, 2-page easier read leaflets with some pictures on them. We've got translations. If you or anyone you know can't speak English, we've got 10 different languages apart from English. It's got the English in there, so you know what the leaflet says. Good move, eh? And we've got fact sheets, and there's 1-page leaflets, and then there's the document on how coming off medicines, for instance. If you loads of ticks there, you end up with a score at the bottom, and that tells you what your chances are of relapsing and what to think about and how dangerous or undangerous something might be. So that's really what I would say about medicines. The brain's marvellous, it's delicate, it needs to be looked after, respect it, because brains are marvellous. And I'll finish off by saying, whatever you do, always give 100%, unless you're donating blood. And I would say, with Halloween imminent, can I just say there is a police warning of some people coming around trying to get money with menaces. It's this lot. And finally, don't drink and fly. Actually, don't text and fly, actually, is the other one I've seen for that. Right, okay, thank you very much.
Thank you.